Hello and welcome everyone. We're so glad you could join us today for episode 5 of the vitalacy Patient Safety webinar series. Today's episode is Patient Hygiene, Adoption versus Implementation. I'm honored to introduce you to our guest speaker, Ann Marie Pettis. Ann Marie brings more than 30 years of experience as an infection preventionist and currently serves as Director of Infection Prevention for UR Medicine in Rochester, New York. She's consulted across a variety of care settings, from acute care to ambulatory surgery centers, and has played an instrumental role in shaping infection prevention efforts at both the state and national levels. A past president of APIC and one of the first colleagues awarded with the Fellow of APIC designation, Ann Marie has also contributed extensively to key initiatives in CAUTI and CLABSI prevention, and has lectured globally on the best practices in infection control. We're proud to have her as a clinical advisor to vitalacy, and we're excited to learn more from her insights today. As a reminder, we'll leave time at the end of the session for a Q&A, and feel free to drop your questions into the chat at any time during the presentation, and we'll do our best to answer them at the end. And without further ado, I'm going to hand it over to Ann Marie.
Thank you, Dan. Thanks so much. And hi, everybody. Thanks so much for joining us today. It's an honor to be with you, and I want to thank vitalacy for inviting me to talk about an important topic regarding patient safety and the prevention of healthcare-associated infections. I do need to make a quick little edit to my bio. I was director at the University of Rochester, no longer am, retired from there, and I'm now an independent consultant. So anyways, just wanted to correct my mistake that was still there. So today, if we could have the next slide, our agenda is pretty straightforward. We're going to be talking about the importance of patient hygiene. At the end, we're going to focus a little bit because again, we don't have a lot of time, so we're going to be scratching the surface. We're going to be talking about implementation science a little bit, and we'll focus in on skin decolonization as our example as far as implementation goes. Next one. Okay, so why are we even talking about hygiene? It certainly isn't the most exciting topic, probably. But just because something is basic doesn't take away from its importance in terms of patient safety and preventing healthcare-associated infections. So it is critically important in terms of prevention. Next slide. So all of us, or probably most of us at least, are very aware of the fact that during the pandemic, we saw a significant and almost across the board rise in healthcare-associated infections, as was published here from the National Healthcare Safety Network. Go ahead if you would. Okay, so fortunately, we're starting to reclaim some of that lost ground. And it's all due to the strategies that we all put in place each and every day to help prevent infections. You know, having a culture of safety, having antibiotic stewardship in place, bundles of care, and so forth and so on. And many of you on this call know it full well because you live and breathe it every day. Next one, please. So really, prevention can sort of boil down to 3 basic elements, and that's we need clean hands, and that's not just healthcare worker hands, but clean patient hands and clean visitor hands. Clean environment, and what we're going to focus primarily on today is going to be the clean patient. So all of those things are very important. Next slide. So there are many benefits of having proper hygiene for patients. We've already mentioned decreased risk for healthcare-associated infection, but also just as important is giving them physical and psychological comfort, self-esteem, and just feeling better. All of those things are critically important for patients' welfare. Next slide. Conversely, if we don't have good hygiene in place for the patients, that can result in some very bad outcomes. We already mentioned increased risk of HAI, but that, as we know, leads to an increased length of stay, which translates into increased costs. And last but most importantly, and that is that death can be associated, increased mortality with HAIs. So very, very critical. Go ahead. Okay, so what are the primary components to patient hygiene? Hand hygiene, obviously. You can't talk about anything regarding infection prevention without talking about hand hygiene. Oral care, bathing and skin assessment, and today we're not going to have time to talk about catheter and wound care, but also critically important elements of patient hygiene. Next. Okay, so basically, this is an interesting inverse triangle, if you will, pyramid. And it comes to us from NIOSH, which is the National Institute of Occupational Safety and Health. And as you can see here, what they're doing is they're rating what they feel are the most effective down to the least effective strategies as far as preventing risk regarding anything. It's not just specific to patients, but they list elimination at the top of the pyramid. And what that's about is actually physically removing the hazard. And honestly, that's exactly what we're doing when we practice good hygiene for patients, is we are physically removing the potential pathogens. Right, why don't you go ahead, please? So again, as we already said, we all know, we talk about this day in and day out, the importance of hand hygiene with all of this. And that's because we know that patients, as well as healthcare workers, can carry MDROs, multiply drug-resistant organisms, on their hands, on their clothing. Certainly, they can be on medical devices. That's a whole nother topic we could talk about. And so the best thing any of us can do, including the patient, is to practice good hand hygiene. Next. Okay, so here's the dirty lowdown on hands, and that is that they estimate about 8% of all infections are transmitted by the hands. Unfortunately, germs can live for a long time on moist surfaces, and we know that people can carry up to millions of bacteria at any given time. And ungloved hands, according to AHRQ, Agency for Healthcare Research and Quality, we know that greater than 50% of the time our ungloved hands are contaminated. And unfortunately, we all know far too well that in general, less than 50% of the time that hand hygiene is indicated, healthcare providers practice it. Go ahead. So we all know, the 5 moments of hand hygiene. So when we practice hand hygiene is certainly critically important, but so is how we practice it. And I'm sure, like me, you've all witnessed where people sort of glide by the hand rub dispenser, and they're certainly not rubbing it in for 20 seconds, and they're not careful about getting to all the surfaces. So how we practice hand hygiene is very important as well. There should be at least 60% of alcohol, and we should be doing it for 20 seconds. And if you time that, that's a long time. Anyways, and then they dictate when we should be using soap and water versus hand rub. So again, I know I'm preaching to the choir here, so we won't go into that any further. But you want to make sure that we always have the appropriate supplies available at all given times. Go ahead. Okay, so here's one that I think often gets overlooked, and that is that having clean linen is certainly part of patient hygiene. And those of us that are nurses, that was sort of nursing 101. But I think as you get busy and as we get overwhelmed, sometimes that falls to the bottom of the list. So it's important to remind ourselves that clean linen can really help protect patients. So if you look at in APIC, this particular white paper was published several years ago, and it's excellent in terms of highlighting why clean linen is a significant aspect to hygiene. Go ahead. All right, so here's Exhibit A in terms of why it's important. This was an investigation that spread out over about 11 months. It dealt with 5 different patients, all of which had a fungal infection called mucormycosis. and these were all in acute care facilities. And unfortunately, all 5 of those patients did die from their fungal infection, and it was traced back to contaminated linen. Go ahead. Oh, I just want to mention too that in June, when we had the National APIC conference, there was an abstract that was presented about the risk of contaminated linen, and it had to do with 2 documented cases, 1 suspected case of aspergillus in the NICU. And again, it was traced back to handling of contaminated linen, and it probably got contaminated at the loading dock where they had the dirty linen at the same time clean linen was coming in, and they did an environmental sample which was indeed positive for aspergillus. So just another example in the literature of what a risk this can present. If we don't tour our laundry facilities, whether they're hospital-based or in our community, we have a community-wide one. So many years ago, our APIC chapter started taking turns. Each hospital would take a turn on an annual basis. We go in, we observe, we do a checklist, we do an education for the staff, and that's proven to be very, very popular and very important. Obviously, the rest of this list is very basic, and we all know it, but sometimes we need to remind ourselves to check that people are using gloves when soiled, they're not putting the dirty linen on the floor, and storage of linen is critically important. Okay, go ahead. Okay, so now we're going to switch gears again. We're going to talk about oral care, and again, critical to infection prevention. And it's because it does prevent infection. It prevents primarily aspiration pneumonia. It prevents tooth decay and actual loss of teeth, gum disease. It certainly increases comfort. Just think of how much better you feel in the morning after you've brushed your teeth. And the last thing is the fact that it can enhance the taste of food. And as we know, a lot of patients just don't have much of an appetite. They're not getting the right nutrition. So anything we can do to enhance hospital food, which is not always the most exciting, is a good thing. Go ahead. Okay, and if we don't use good oral hygiene for patients, we're looking at the chance of causing aspiration pneumonia, as I mentioned. And we know that hospital-associated pneumonia is the most common HAI in the United States. And what some people might not realize is that it is more common than VAP, ventilator-associated pneumonia, or VAE. And that's something that we sometimes lose sight of, I think. And it's because of our patients. They have decreased mobility. They might be on, a ventilator, have an altered mental status. And so again, that aspiration pneumonia becomes a real risk. Go ahead. Okay, so it's hard to argue against the importance of a daily bath. That would make no sense to argue against that. But are there risks to bathing? And indeed there are. We know that having intact skin is a natural barrier to infections. And so we also know that soaps and washcloths that are rough can damage that fragile skin. And last but not least, we know, based on literature, and I'll show you some, is that contaminated wash basins can lead to infection. And so all those things are potential risk factors, even though we're trying to keep people clean. Next one. Okay, so this was a good one. This one was from 2012, so it's a little older, but it was in American Journal of Critical Care. And in this one, I think there was 3 different hospitals that they did the study in, and their bath basins were cultured, and 98% were found to be contaminated, primarily with gram-positives and gram-negative organisms, but 98% of the ones that were cultured. So sort of surprising. Next one. So here's another interesting study regarding reusable bath basins, and this one was an observational study. So go ahead. Oh, and I will mention Kathleen Vollman. This was done by Quinn and Vollman, And she's probably one of the most vocal people that does a lot of education about the importance of, or the risk of, contaminated wash basins. So anything that Kathleen writes is something you might want to take a peek at. But this particular study that we're looking at today, thousands of basins were sampled at hundreds of healthcare sites, acute care sites. And you can see that almost 60% of these basins were indeed contaminated, anywhere from 1 to 3 different organisms. So, pretty eye-opening, if you will. Go ahead. So now we'll talk about, all right, what else besides bathing can we do to prevent the skin from becoming an issue in terms of HAIs? So topical decolonization is an important concept. And you can use either an antiseptic or antibiotic agent. Antiseptic would be more like CHG, sometimes iodophor. Antibiotic would be, an example would be mupirocin. So on the skin, you're looking at things like Hibiclens, Sage Striker has a product. So there's a variety of products on the market. And in the nares, which also can be a real source for organisms, you're primarily looking at either mupirocin, alcohol-based swabs, or an iodophor. Can we go back just 1 second? Yeah. So CHG does have a very excellent safety record. And the good news is that it does not seem to disrupt the patient's normal skin organisms. And so it can either be used as a targeted approach or a universal application. So again, it's very available, it's cost effective, it's a cheap way to do it, and it's non-invasive, which is nice. Okay, I'm sorry, go ahead. So universal decolonization is an example of what they call a horizontal approach versus a vertical approach. Vertical would be, okay, we know a patient has a certain organism, so we're going to apply a certain strategy. This is where you're using a strategy across the board. And in the literature, a universal approach has certainly been shown to be very effective. It also eliminates the need to do screening upon admission or on a daily basis or whatever. It's been shown to reduce blood culture contamination. It reduces finding bacteria and candida at least in male urine. That's where the studies were done. No emergence of CHG or mupirocin resistance has been shown in trials. Mupirocin is still sort of a theoretic risk. Certainly could happen. CLABSI benefit has been seen in, a lot of different hospitals, 95, according to this particular study that I gave you. And by 2021, we were already seeing over 50% of the hospitals in the United States had indeed adopted a universal ICU decolonization approach. So not necessarily out on the units, but in the ICU. Go ahead. Okay. So as I said, you can use it in intensive care units. You can use it on regular units. And we have studies that have actually looked at how successful those implementations have been. And I gave you the 3 studies, but they demonstrated a decrease in MRSA, bacteremias, and so forth. So, when you get a chance, you might want to take a look, if you haven't already taken a look at these are real seminal studies that have been done, well done studies. Go ahead. So these are the different products. We're going to stick with CHG right now. You either are looking at either a 4%, and that's usually a foam. It can be a liquid. It can be given to preoperative patients who then use it in the shower, the day of the surgery or the day before, or sometimes they'll last for a couple days worth. Also, you can dilute the 4% in a bath basin. But again, we've already talked about bath basins, so you do have to be careful about that approach. Or you can use the 2% approach in the different cloths that are manufactured, and there's different manufacturers. These are really neat because they're sort of like a bed bath in a bag, if you will. And the difference, though, between the two is these are meant to be left or the CHG is deposited on the skin, and it's meant to be left to dry on the skin. And that's one of the mistakes that gets made, is that patients don't always like the initial stickiness that they feel from the aloe in the wipes, which is actually a good treatment for the skin, but they don't like the way it makes them feel. It does go away, and it's important the staff knows that so they can help the patient understand it. But anyway, so we'll talk a little bit more about the pitfalls. But those are the two different approaches that are used. Go ahead. And not only can it be used in acute care, but there is literature, studies that have looked at it being used after discharge from a hospital, as well as in a nursing home. And that's one of the most recent studies, the PROTECT trial, where they actually saw a 20% reduction in multiply drug-resistant organism carriage in nursing home setting, which is pretty exciting. So that's one, if you haven't already taken a look at. A lot of our organizations are responsible for nursing homes and whatnot. Go ahead. Okay, so now we want to spend the rest of our time talking about adoption versus implementation, and we're going to continue using as CHG, skin decolonization, as our example. It's one I'm very familiar with because I really screwed it up in my own one of my own organizations. And I really learned the hard way that adoption is not the same as implementation. And we also know that because there's a real lack of information about how to implement an evidence-based practice, what that does is it leads to what they call the knowing versus doing gap. There's a huge gap in time between when something's discovered and reported in the literature versus when there's widespread adoption. And we know that it can actually be up to 10 years or more that something, even though it's been proven in the literature, where it gets readily adopted across the board. Our patients can't wait 10 years. They need that on a much quicker basis. And so implementation science is absolutely critical. So implementation information and resources should be a standard element anytime we're trying to implement a new practice. And the first reference that you're going to get at the end, we're not going to have time to talk much about it, but the first one is going to be what I think is probably the best reference. And we published it as a companion document to the Shea Compendium that was put out in 19, oh my God, you can tell how long I've been doing this, in 2023. And it's called Implementing Strategies to Prevent Infections in the Acute Care Setting. And what it is, it's a 15-page document. It can either be a standalone document, but it does come along with the compendium. And we published it because we felt the need to actually provide resources and frameworks, samples of different models that have been used successfully to create sustainability. And so I would highly recommend that to you. Again, we're just scratching the surface, but I wanted you, if you aren't already, many of you I'm sure are, but if you aren't, you might want to take a look at that. Next one. Okay, so the what versus the how of trying to implement something. Successful implementation takes a lot of time, takes an unbelievable amount of effort, if you will. And basically, the what is really hopefully coming to us from randomized control trials. So it's the science. And so we realize, oh, it looks as though we need to implement something new. The how comes from implementation science, which has to do with strategies, tools, technical. They're technical sometimes they're socio-adaptive. They have to do with behavioral change. And they've been shown to be effective in the literature in terms of creating sustainability, which is the most difficult thing to achieve. It's never one and done. And that was the mistake that I made, is that I knew I was excited about this new strategy of doing decolonization in our ICUs, but I just didn't check on it frequently enough. And so 3 months later, I realized, oh my God, we're not seeing any change. And sadly, the reason we weren't is because the staff really had not implemented it. Go ahead if you would, Dan. All right, so you have to assume that there's going to be implementation barriers. Human beings really are very uncomfortable with change, as we all know. And so you've got to anticipate that there's going to be barriers, which again, I did not do very well. So right off the bat, what I realized after the fact is that there were a lot of staff product concerns. And they were afraid of allergic reactions, which really there have been none across the board around the country. They were concerned about, is it going to create microbial resistance? Excellent concern. But again, I would have been able to help them with that. Were they able to use it in the perineal area? We better not use it around lines and drains. And actually not true. It's encouraged that you use it around lines and drains. As long as you avoid the ears, you can put it on the face, you can put it in the vaginal area, and so forth. The last thing they were very concerned about is, all right, well, is it compatible with other agents that we use on the skin? Well, I'd already cleared that with the skincare specialist nurses. So, but again, did I do a very good job making sure everybody was aware of that? Last but not least, patients didn't like it. And so the staff didn't feel fully armed with the information to help overcome that. So it's important that with something like this, that they knew that it was actually a treatment versus a bath, because the patient will say, you know what, I had my bath yesterday. I really don't feel like I need one today. And instead, the nurse said, oh, okay, fine, don't worry about it. But instead, if they'd said, well, this really is a treatment to help protect you from infection, most patients would probably say, go ahead. So barriers, you got to anticipate them. Go ahead. In this case, success definitely depends on how you apply it. And these are application pearls that have been in the science, in the literature from the studies that have been done. This is an example of one. Avoiding cotton cloths. Cotton absorbs the CHG, so it doesn't land on the skin as much as it should. And again, checking that compatibility is key. I think we'll go ahead. So another key component in the science of implementation is that standardization is key. You have to standardize the way people are applying whatever it is that you've asked them to do. And so checklists become critically important. And, assessing on a daily basis, how are people doing it? Are they doing it correctly? Are they documenting all of that? So very important element, standardization. Go ahead. Another key concept, you need facilitators. You need people that are on the unit. They might be formal influencers, they might be informal influencers, but you need champions. And this particular example that I gave you was actually a nurse's aide, and she understood that patients were being protected from infection. So she became a champion off the, right out of the gate. And fortunately, she had a lot of influence with her colleagues. So again, this is such an important component. And you really got to know your staff, and you got to know your managers so that they can identify who are the people that really have sway with our colleagues. And so champions, having a facilitator, very, very key element. Go ahead. Okay, so, each and every one of us has a role, whether we're IPs, which I know many of us today are, infection preventionists. But what if you're the nurse or the tech delivering care? You have a role to play. What if you are the value analysis person, or the person that works in, products and so forth, that makes sure that the products are available? They have a role to play. The quality improvement leader or the infection preventionist, we're the ones who track the bad outcomes and we promote improvement. We obviously have a huge role to play. The value analysis people, the supply chain people, what if what if you come from the C-suite and you're the chief financial officer that has control over the purse strings? You're going to make sure that that the resources are available to purchase, new products and things that have proven to be effective. And sometimes as IPs, we know that that's our most difficult job, is presenting all the evidence in a language that they understand and that they will then wrap their arms around it too. But we need each and every person in the organization to be part of this team as we implement good not just hand hygiene, patient hygiene. So we need to make sure that hygiene is delivered on a daily basis and on an ongoing basis during our shift or during the day, practicing our own good hand hygiene, creating a safety culture where we actually keep each other accountable in terms of our practice, providing visual cures, changing those, or cues, not cures, visual cues, changing those they become like the wallpaper if you don't change them frequently, and they've got to be eye-catching. Providing patient and visitor education. They may not understand that they play a role. Making sure that everything is conveniently located, that it's well stocked, that it's working correctly. And then auditing and reporting compliance. And perhaps most important of all is, and we all know this, but do we do it enough? And that's celebrating any small improvement that we see and making sure that the staff feel rewarded and that they understand how critical their role is, and that obviously we couldn't do it without them. Next slide. So as I said, this is that implementing strategies resource. There's many other resources that I use to create the slides. Go ahead. So, these may or may not be useful to you. Go ahead. And so last but not least, I just want to thank you all for being with us today. More importantly, for everything you do each and every day. As I say, we all have a role to play, and we all are trying to protect our patients from healthcare-associated infections. And our loved ones might be hospitalized, will be hospitalized at some point. So thank you for everything that you do. And now I'm going to turn it over to Dan, I think, to see if we've got time for questions.
We went over a couple
I would
minutes.
love to hear comments.
I think that we could take a few questions. We'll wait for people to submit them. It might take a minute for them to come through.
Okay. Or a success story that maybe you've had, or a problem that you ran into like I did.
One question is, where do you see the most opportunity for improvement in patient hygiene today?
Well, my personal experience has been with oral care. I think a lot of times our patients just, if you open their mouth, you see that they really have not had consistent, good oral hygiene. And, again, they may not feel like it, but we need to educate them about the fact that it's not just about feeling better, it's about preventing infection.
Ellen said, thank you for the emphasis on implementation. We have recognized this as a miss for us as well. Bonnie
So
said,
true.
thank you. Currently trying to build an oral care education program. This was helpful.
Again, we just scratched the surface, obviously, with all of this. But yeah, I think the resources at the end there may come in handy if you don't already have them.
I think that that's it so far. If you have any further questions, please feel free to reach out after the webinar and we can answer them. Ann Marie, thank you so much for being here today and for your thoughtful and practical discussion. I hope everyone enjoyed our webinar episode today. If you'd like to revisit today's episode or explore previous sessions in our patient safety webinar series, please visit vitalacy.ai. We appreciate your time, your questions, and your continued commitment to patient safety, and we'll see you next time.
Thank you. Bye-bye.
Thank you.